Right, hello everyone. Again, we actually are not going to focus this talk on the NIATEX model. This is really a short talk. We're going to catch up on our time and try to get to 3:15. So if you have questions or thoughts, please jot them down as you go along, and I'm happy to answer them during our break. So I'm going to speak for about 30 minutes on coaching and facilitation as a discrete implementation strategy. So yesterday when I spoke, we pulled out some of the key strategies, and coaching and facilitation seems to be one of them. That these strategies actually power implementation. So we're going to drill down on that a little bit. And as I did, I would like to just center the conversation always by reminding us all that we are just where we are. It is what it is. If we can accept where we are, we may find that gentleness, decency, and bravery are available, not only to us, but to all human beings. So I offer this conversation in the spirit of that idea. Learning objectives. Review the evidence for facilitation as an important strategy in implementation. Discuss different ideas about facilitation. Discuss approaches to facilitation, and explore the importance of selecting facilitation tools that suit your implementation strategy. I also want to just shout out to our faculty and to each of you who asked questions or gave presentations. I really altered this talk in context of trying to include some of that feedback. So Dr. Altiz yesterday introduced ERIC, or the Expert Recommendations for Implementing Change Study. And ERIC compiled and described implementation strategies. This is a paper that was published in 2015, so going on just about a decade ago or so of work in this area. And ERIC describes 73 discrete strategies for implementation. And I don't know about you, but when I see the number 73, and then I think, okay, I'm going to try to match that with whatever it is my challenge might be right now. That feels like a big number to me. So I've been wading into 73. And Eric actually did, which is also the name of my brother. So it's kind of weird. I keep evoking the name of my brother here, but Eric defines facilitation as a process of interactive problem solving. So this is an important verb here. It's interactive problem solving that differs very much from kind of traditional educational offerings, right? As a process of interactive problem solving and support that occurs in a context of a recognized need for improvement. So we're doing implementation because there's already some acknowledgement of a need for change and a supportive interpersonal relationship. Coaching is another term to describe this same process. So important ideas here. This is a process of interactive problem solving in the context of a recognized need. Now, facilitation is a key element of implementation. It has been cited as the most important or among the most important tools for successful implementation. And coaching can take many forms, but it's most commonly organized initially as external support. And I just was listening to Dr. Haddad, and I saw another example of interesting facilitation, of really using technology or digital technology to really do some interesting kinds of facilitation. So here's some evidence now. So Eric is about 10 years old, and this evidence is about 20 years old, or even a little bit older. So what does this really say? This slide is from two different studies, one in 2001 and one in the year 2000, that really point to facilitation as the key to successful implementation. So across the top, you can see does the site have an implementation team? Yes or no? And is that team facilitated? Yes or no? So when we talk about the do gap, right? What is the gap between knowledge and doing? That is a 17-year gap, as many of our speakers, including Dr. Davis this morning, invoked that for us, right? So implementation science is really built on the idea that we're trying to close that gap. 20 years ago, the data looked about the same as it does now, right? So I think that's really fascinating. What we see is that you can close the gap in about 3 years with effective use of implementation science in practice. But you can't do that by just letting information or new knowledge out into the atmosphere and hoping that it will have uptake. Facilitation seems to be the key to this phenomenon. Learning collaboratives, this is another study. This is from 2013, so pretty much in the middle here. This is from the research question was actually which elements of improvement collaboratives are most effective. So this was a cluster randomized trial with 200 substance use treatment sites across 5 states. And the conclusion was pretty straightforward. Coaching and the combination of collaborative components were about equally effective in achieving the aims of this particular study, which were to scale up evidence-based practices for substance use disorders. But coaching was substantially more cost-effective, right? And I think with the wrinkle of telehealth or telecommunication, we can achieve even more cost effectiveness using some of these techniques, right? That wasn't particularly available in 2013. So important here, what were the drivers in this particular study of scale up or effective scale up, coaching, and other collaborative components, right? So really important. You can see that not all implementation strategies, when you really take a look at the literature, there are 73 of them that are named, they're not all created equal, right? So that's an important, I think, consideration these days when one is trying to design a study, for example, or solve a problem. In 2019, so getting a little closer to the present day, Lydia Musa and colleagues undertook a systematic review of what they considered successful facilitation strategies. Now, success in this case is defined in the same way as on the previous slide, which is were the study aims actually reached in the study. So successful facilitation strategies included the following attributes: goal setting, assessing progress and outcomes, and providing tools and resources. Right? So we're getting a little closer to some kind of definition. So the question becomes, how does facilitation actually work? And as is really common in implementation science, we know that certain strategies show evidence of working. So ECHO shows evidence of working, we can see that, but we really don't know how exactly. Right? So we create these interventions or approaches or strategies and we test them to see if they work. But if you're interested in sort of mechanisms, we don't really know how facilitation works. So healthcare facilitation, Amy Kilborn and her colleagues, healthcare facilitation is an implementation strategy that has produced promising but mixed results in randomized implementation trials and has not been fully researched across different contexts. So for those of you who are students, this is a real opportunity, right? We know that something works, we're not exactly sure how it works, we're not exactly sure if this phenomena of facilitation will extend, for example, to humanitarian crises, or will really further advance equity in particular public health issues, because we haven't really looked at it in this way. So here's 2 other studies that try to get at that question. How does this work? One of them, the black box of coaching for implementation. I was involved with this study. This was a series of 9 qualitative interviews with coaches who were considered successful. Though using that previous definition, coaches who have been involved in successfully implementing studies or moving toward aims and trials. And we also did 40, we looked at 40 previously recorded coaching calls, and which underwent direct content analysis using codes based on the model that we developed out of the qualitative interview. So there aren't coaching models, or not many of them. There are acronyms, do these things or use this approach, right? But there aren't actually models of coaching until quite recently. So the analysis results in this case in a 3-phase model of what happens, right? So when we start to answer the how question, what gets answered partially here is what actually happens when coaching for facilitation. And the model lays out 3 phases: building relationships, building capacity, and building sustainability. And various tools are associated with each of these phases. So this was published in February of 2023. So you can see phase 1, phase 2, phase 3 going across the screen here. You can see the tools that are primarily associated with phase 1, setting goals, doing nominal group technique. In phase 2, you're essentially beginning to actually help people stay organized. By the time you move to phase 3, you're really thinking about sustainability. But overall, these phases are surrounded with a circle that is that uses a framework of encouragement and positive reinforcement and continuous troubleshooting on behalf of the coach. So how does this framework really come up with? Listening to people do coaching calls. So we listened to 40 coaching calls. And this is the result of that. This is the analysis of that, right? So an interesting bit of research into a research strategy. So here's another paper, also from 2023, but about 3 or 4 months later, another look at the so-called black box of facilitation. And this study used a modified Delphi consensus method to try and determine how facilitation works in various contexts. So the previous study is looking at what happens in a coaching call or a coaching interaction. This one is looking at how does this really work in different contexts. And again, 3 thematic areas emerge: facilitator characteristics, organizational and material resources, and contextual factors. Each area is described, in this case, by facilitator actions, selected tools, and what they call organizational sense-making. How did an organization make sense of receiving coaching? I think this is such an interesting question, right? What do they call it? How do they make sense of it? And they used a mechanism, they used a mapping mechanism to really try to elucidate this. And here you go. So Amy Kilborn and her colleagues, here's their model. You will have access to these slides and you'll be able, I think, to read it a little better than I can right now. But what you can see is that they too drew an ellipse, right, an oval around this whole process. And you can see from the arrows that are here that there's a movement back and forth among these 3 areas of influence, which are the facilitator characteristics, and the organizational, human, and material resources, and then the contextual factors. So both of these models, if you will, that are attempting to explain how or why facilitation actually works, are multifaceted and non-linear ideas. And they lay a lot at the feet of the skill or characteristics in this model of the coach themselves. Right? So this kind of brings together the idea of, what kind of skills does a person really need to have in order to be a successful coach? So some of the tools in here, the healthcare facilitator is delivering iterative and adaptable technical and socio-behavioral intentions for practice change. This is something you also see in ECHO. We certainly see this in NIATEX, right? We see this in quite a number of ideas about how to successfully implement change. We heard yesterday about building trust when Dr. Helen was giving her talk and Dr. Michelle yesterday afternoon. How do you build trust? by really identifying opportunities to develop organizational capacity, right? How do you adopt practice change? Some of the fascinating ideas here, the contextual factors, and the sense-making that I referenced. You know, one of the factors mentioned here is the routinization, the normalization of new approaches, right? Disseminating practice insights, right? Acceptance of the coach in the organization. So really interesting, quite recent work that I think gives some real opportunity. There are other ERIC strategies. Yesterday I read all 73 of them again. That some people might consider coaching. One of them that's used quite often is audit and feedback, right? Audit and feedback is sometimes automated, but more successfully is generally led by a person or a team. And audit and feedback is a way of collecting and summarizing clinical performance data over a specified time period and giving it back to the people who are actually creating the data and their administrators to monitor, evaluate, and modify provider behavior. So that sounds a lot like the other kinds of coaching that we're actually talking about, right? Start with a problem, develop the data, involve people in looking at the data and in solution setting, and see if a change actually happens. So audit and feedback, sometimes we call this dashboard, right? And some EHRs now have dashboards built into them. My experience of dashboards, for those of you who are looking at the use of dashboards to try and do research, is they're way too complicated. In general, you need 2 or 3 data points to focus on if you really want to know if the current intervention is actually suggesting a change or not, or is facilitating a change. Another ERIC strategy that some people consider to be coaching is the relay of clinical data to providers. So you can see how much overlap there is here, right? This is provide as close to real-time data as possible about key measures of process outcomes using integrated modes and channels of communication in a way that promotes the use of the targeted intervention. Still relying on ERIC, organize clinician implementation team meetings, develop and support teams of clinicians who are implementing the innovation. So if you're supporting them at some level, there's facilitation happening here, right? And give them time to reflect on the effort, share their lessons, and support one another's learning. So there's a lot of different models that all lay out the same sort of spheres, right, of developing relationships, developing capacity, and then promoting sustainability. A fourth one out of ERIC, provide ongoing consulting with one or more experts in the strategies used to support implementing the intervention or the innovation. And then lastly, to use an implementation advisor. Seek guidance from experts in implementation. If you do that in a repeat fashion, as sometimes described in various types of organizations like NATAP that are actually delivering technical assistance and education, this too is seen as a kind of facilitation or coaching, right? So really important message to take away from the previous part of this talk is that we know that facilitation works. And in some studies, facilitation actually seems to be the thing that works to implement the thing, right? So that's really important, that if you have to select strategies, which you're going to have to do, it's really useful to select strategies that have an evidence base that's robust behind them in order to justify what you're actually doing. So I want to switch gears just a little bit and move into some facilitation techniques. And this one is motivational interviewing. Do we have people here, clinical people who are trained in motivational interviewing? Yeah, thanks, Dr. Haddad is over here too as well. So motivational interviewing was initially a counseling approach, right? Developed by 2 clinical psychologists, William Miller and Stephen Rolnick, back in, they first published in October of 1995. It was revolutionary at that time that you would actually consider collaborating with patients as opposed to knowing what to do and telling the patient what to do. So you can hear already how that seems a little more lined up with ideas around coaching, right? So this really positions the clinician more as a listener and a person providing feedback than necessarily a person who already knows everything that's right for you. That sounds like coaching, right? That sounds a lot like coaching. So motivational interviewing, or some people say MI, it's designed to elicit behavioral change by helping to recognize, explore, and resolve ambivalence. So what's one of the biggest factors that actually impedes change? What gets in the way of change? One of the key factors that often gets in the way of change is that people don't want to change. Right? Organizations are at a status quo sometimes. They really don't have much interest in being different. People feel busy. People feel satisfied. So we run into this in all kinds of healthcare fields, right? People don't want to be tested because they don't want to know the answer. People may not want to engage in substance use treatment because they don't want to stop using substances, and they think those two things are the same thing, right? So you run into ambivalence all the time. So there are a couple key principles I want to just bring up and ask you to think about absorbing or adopting in your role as coaches or facilitators. And the 4 principles of motivational interviewing are: resist the writing reflex. And what that means is don't tell people what the right answer is, right? Resist the writing reflex. Understand the person's own motivations. This is the tricky part. So later today, when we talk about nominal group technique, and we actually do one, here's a way of starting to bring people's opinions into the room. Yesterday, for those of you who were in the room that I was giving a talk in, we talked a little bit about location. Who are you? What do you bring to the room? Who is the person or group that you're talking to? What do they bring to the table? Dr. Helen really brought up a lot of ideas about learning to own her own location and how she perhaps didn't consider particular groups in the initial formulation of her work, right? So learning about location or understanding a person's motivation is a key idea in MI principles, as well as a key coaching idea. So if you go back to those 2 coaching models, there are many aspects in each of those models that bring this concept to the front. You need to listen with empathy, right? Empathy is a skill. Like most skills, it can be developed and enhanced, and it's not always available to us at the same level every day. Right, so empathy is a skill that you can develop, and that you can encourage your colleagues to develop, and you can encourage the persons with whom you work, who may be the object of the intervention, to actually develop as well. Right, empower the person or the organization. So there's a number of ways of doing that. So 4 principles of motivational interviewing, and then I'm going to talk through these processes, right? So there are principles and processes. The principles, again, to me, look so much like how we describe facilitation or coaching, engaging. You want to align with empathy. This is right out of the original work from Rolnick and Miller. You want to align with the individual or the organization with empathy. The first coaching model that we described today, we talked about this as building relationships. In this second coaching model, there's a whole area in the top right-hand side of that model that talks about building trust. Right? So you want to engage with whomever you're working with some empathy. You want to focus. What are you really trying to do? Right? So talking to people is really fun and interesting. But you can spend a lot of time talking and not really get to the point. The same thing happens in coaching and in implementation science, right? It's very easy to take detours, and what this model suggests is to really focus. What are you doing? What do you want to change? You want to figure out how to evoke the why, right? Why are we trying to make this change? What is the urgency? Right? So when Dr. Kushner was talking about humanitarian crises, you know, it's more clear when we discuss crises what the urgency of the situation is. It's less clear how to actually engage that. What do we do about some of those things, right? So conversely, in some more traditional implementation science frameworks, it's less clear from a science point of view, or at least in the communication of it, that why we're trying to do these things, right? So that sense of urgency is really important to bring that sense of urgency forward and to continue to use it in the conversations that we're having with people. And then the planning phase, how are we going to do this? So what are we doing? Why are we doing this? And how will we do it, right? And all of that sort of encapsulated in this set of ideas around positive frameworks and aligning with empathy. These processes are not necessarily linear or definitive of facilitation. So although we're trying to answer this question about, you know, how do you do this? What is it? We don't have a full understanding of the mechanics. I spoke a bit yesterday about appreciative inquiry. It's worth bringing back to the table. It's another a very classic kind of psychology technique along with motivational interview, but it's an asset-based approach to dialogue and engagement. Appreciative inquiry, I think somebody should also write about this, the use of appreciative inquiry at the community-based level. How do you engage communities using ideas around appreciative inquiry? Right? There's a real opportunity to think about equity and social justice, because asset-based approaches are not always used in these conversations about equity and social justice, right? But often, in fact, I was having a conversation with Dr. Helen over lunch, often, in fact, instead what we're doing is we create groups out of those folks who don't have equity in some way. So they're a group over here, as if they have everything in common, right? There's some kind of monolithic group that exists over here. These folks need equity. Well, we don't actually know what they need in many ways, right? We just know that they're not getting what people who are in a different category are actually getting for opportunities. So appreciative inquiry may be able to be applied in kind of these conversations about equity and social justice, and how implementation strategies can actually be affected by those constructs. And when we practice appreciative inquiry, it's to employ these key approaches, ask positive questions, right? Find and share positive stories, and practice playing different kinds of roles. There are other ways of doing this, but again, I would suggest that these are the key ideas. If you ask somebody to tell you something positive about themselves or their circumstances, you are positioning them in a different way than you might be if you consider them to somehow be a disadvantaged group. Right? You are allowing the advantages that they perceive to come forward and be integrated into whatever solution set may in fact develop as you're trying to facilitate a problem solving. So choosing facilitation tools and approaches, really in summary here, one key challenge to selecting tools that drive implementation is that context is so critical. Context is so critical. A medical practice in a resource-rich environment is not the same as trying to figure out how to get services to people who are living in a conflict zone. Right? Context is so important, and it's not the same to do research in those particular spheres either. So, and I'm not really only talking about sort of cross-cultural implications. I'm talking about really contextual implications, right? So the who, what, why, and where is always an important consideration. Understanding context does not occur before implementation approaches are theoretically conceptualized or funded. This is just reality, unless you've had the opportunity to work in that field, right? So again, I'll evoke Dr. Helen's story from yesterday afternoon, because I thought about it all evening, really. You know, how you really recognize that you don't understand the context. And say that out loud and reshape what you're actually doing is such an important skill. But you also have to get funded in general if you're a researcher. So what do you say up front becomes, I think, relatively challenging, right? This is why choosing facilitation tools and approaches based on what you understand theoretically and being able to defend those choices is really important, right? It's also important, if you go to the third point here, to choose families of strategies so that you can maybe change your mind a little bit, or you can shift as you're engaged in the research, right? So if you choose families of strategies, for example, we'll talk about barriers and facilitators for just a second. Maybe you choose a family of tools, individual interviews, nominal group techniques, focus groups, using this cool interactive tool online, or 3-day-long kind of digital interactions with people. Choose a family of strategies that's potentially, you can defend that, and it gives you perhaps a little more flexibility as you move through your research, right? And sometimes you just really have to shift in the middle and think a little bit differently about what you're doing. But understanding context is critical to choosing the proper tools. Really be prepared to pivot as context becomes more clear or shifts. I was involved in several projects that shifted dramatically with COVID, and we really had to learn to pivot. And in some cases, we as teams did better than others, right? Because we were wed at some level to strategies that weren't especially flexible. And then there is the CFR ERIC tool. Dr. Altice mentioned this yesterday, but I think it's worth repeating. This tool identifies which ERIC implementation strategy might, it's a proper word here, this is research, might best address specific contextual barriers as delimited by the CFR or the Consolidated Framework for Implementation Research ideas. So a logically based justification of discrete implementation strategies is increasingly necessary for funding and for obtaining stakeholder support. Right? I am always, for those of you whom I've had the pleasure of talking with over the last couple of days, and some of you last year, I'm always going to advocate for ways that bring in voices of multiple stakeholders. Right? But I know that there are many, many ways to do that. Right? So logically based justification of your strategies is really necessary for funding. The other thing that's really necessary for our field is to keep looking at these defined strategies and to find ways of understanding them better and their application to the particular implementation challenges that we face at any given moment. So with that, I'll happily take questions. It's 3:16. I said I'd get us back on track for 3:15. So. Any questions or comments, or people just want to do that over break? Yeah, please.
Thank you very much, Dr. Lynn, for your presentation. Okay. I am still organizing my thoughts in forming this question, but I'll try. My name is Aisha from Cancer Research Malaysia. So part of the strategies that we take to expand our patient navigation program is by conducting coaching session through ECHO. Okay, so I'm also still new in this, and from what little I know is that there's this requirement that we have to conduct the training for at least 12 months. Now, I'm probably mixing up a lot of things that I learned for the past 1.5 days, but given that there's this requirement that we need to conduct this for 12 months at least, and then I recall what you taught yesterday about PDSA cycle, how the change that you introduced should be measured within 2 to 4 weeks. So I'm just wondering, like, how does, and it's only natural for coaching to take some time for the effect to be seen. So I guess perhaps you can enlighten me or perhaps help me to organize my thoughts between all these different tools and new things that I've been learning, like how do all these things work together and how can we best measure the effectiveness of coaching using ECHO platform?
That is such a great question, and my colleagues, Dr. Haddad in particular, can maybe give you a different answer. I am involved in several studies and have been for over the years that really combine a kind of classic coaching approach with ECHO, right? So that there are these implementation strategies using more direct one-on-one and PDSAs that are also and participants also have access to ECHO. I consider them to be mutually supportive, and I particularly discuss ECHO as a support to whatever the aim actually is. So if the aim, for example, is to scale up buprenorphine prescription, as the example that we all just saw, then you might be doing PDSAs that are related to how do you schedule these patients, or who actually sees them, or how much time do you have to spend with them, or what does the order set look like, right? What does the evaluation set look like? Is it different than, so those PDSAs might be ongoing and informed by the ECHO session. The PDSAs are going to be process-oriented. They'll be process measures. ECHO is actually measured in many ways by the acquisition of knowledge, as Dr. Haddad presented, and the shifting of comfort and skill sets among the persons actually participating in ECHO, right? So you get mutually entwined results, and I think mutually supportive strategies. Because on the flip side of that, what if you're just learning as a practitioner how to do something? Okay, now I know how to prescribe antiretroviral therapy. But maybe I don't have any patients with HIV. Or maybe the intake process doesn't actually test for HIV, right? So I might know how to prescribe, but I'm not actually prescribing, because the processes of my practice don't support the identification of those patients. Right? Does that make sense? Yeah. I don't know, Dr. Haddad, if you want to take a stab at that. No, good. All right, let's go to break. And thank you again. I appreciate your time.
So it sounds like the other group is a little behind, so we'll have like a longer break than them, and then we'll come back here to do a nominal group technique session, right?
Yes.
Exciting.